Respected Chairperson, my dear colleagues, I'm just dealing with the techniques and devices already there. Surya Prakash dealt with the wires. Anterograde technique, retrograde technique, devices, complication of data, I just go through that. Usually, a CTO intervention will benefit the patient even with LV dysfunction. Is a 43-year-old man with a severe LV dysfunction with a 20% EF, completely blocked vessels throughout, including RC and left. I'm just showing that this has actually resulted in intervention. Very bad patient. This was a result, and just finished there. And the patient, after 4 months, improved dramatically, gained weight from 25 kilos to 45 kilos, can do normal activity. This was the angiogram. And subsequently, I went, opened RCA and OM. Basically, an CTO intervention requires a good angiography and read it completely before the PCI. This is actually the master's telling. The same thing, actually the examination of an excellent angiogram to succeed a CTO procedure. A crucial point is examining angio well. You have to do a repeat angiogram and a routine angiogram to see all the shots in different angles. This is actually very important in a CTO intervention. Just see angiogram in multiple projections. See, take some time, examine properly, then go for the procedures. That will help you to have a success. Any angiogram lesion morphology, tapered stump, functional occlusion, absent stump, a total occlusion. Actually, there is some favorable point as well as a doesn't favor. But 5 important points. One is a tapered or not, calcified or not, bending with more than 45 degrees or not, then occlusion length is less than 20 millimeters or not, a retry lesion or not. If it is given 1 point each, if these are not there, then it is an easy CTO. As a very difficult CTO means if there is a 3 points, that means not tapered, calcified and bending more than 45 and occlusion length more than 25 millimeters. Points are basically the catheters, guide wires, technical advancement and new devices in Anterograde. Basically, when you have an angiogram in a CTO, always to have a bilateral injection. And there is another important thing is a guide catheter support. JR may not be supporting, you have to take an amplats, then will have an excellent success. Next thing is the guide wire. You can have an Anterograde technique, retrograde and cart. Basically, Anterograde, you have a controlled drilling versus penetration, parallel wires and star technique. Previously, people were using floppy wires with a microcatheter. Now, the hydrophilic coated wire as the first choice even in the Japan operator, next change to ST4 wire. This is actually seen in EuroCTO Club also. My strategy is actually a probing technique with using a floppy plastic coated wire. Then go to a control drill and a penetration. A simple floppy wire is a plastic coated wire, may be successful in most of the CTOs initially. You just pass a wire with the help of an over-the-wire balloon or a simple balloon, you can be succeeded. But some of the time, the standard shaping of the wire may not be useful. You may have to go for the secondary curve. In some situations, you require a special curve made in the proximal part. Tip of the wire is always important. This is actually a case where I made a CTO segment is between these two wires. Secondary curve made me to success in this case. This is close with that. Another challenging case is actually a CTO of the circumflex with ostial LAD, which is 90%. Here, the toughest point is actually I've taken a wire floppy, simple floppy, which is not crossed, then taken a miracle, which is not crossed, miracle with the balloon not crossed, then miracle. This is actually a Congress Pro 12, which created a success, which I crossed. After that, I exchanged with over-the-wire balloon. With the balloon help, resulted in a success like this. Advanced supporting techniques actually, mother and child, anchor balloon, microcatheter, etc. are there, and advanced wire technique is escalation technique. Sometimes a guide wire support itself, without an anchor balloon, can help you to put just a wire in the side branch. It may be helpful in passing the wire down and completing the procedure. Escalate the guide wire is one technique which I usually practice. This is actually a simple looking CTO, but a plastic or a floppy wire did not cross. I tried. Change a wire to a filter XT. which is also not, you can see the tip is actually in a different angle. Check tip not in the right lumen. A miracle 6 wire, tip looking promising but not crossing. A miracle 6 wire with OTW, again not able to cross. A different angle with a Congress Pro 12 showing promise, that is Whisper, Filter XT with OTW, Miracle 6, Miracle 6 with OTW, then Congress Pro 12, given the success. Sometimes the escalation is not like this order. I just escalate straight from the filter FC. This is actually a CTO short segment but not crossing. Very tough CTO, not crossing. Here, I just directly went into the Congress Pro 12, looking promising, but the Congress Pro 12 with the OTW. Lesion crossed, so the success is created, simple. Here the filter FC, Congress Pro 12 with OTW changed to a floppy wire. So you can have an escalation gradually, escalation rapidly. Sometimes the balloon may help you in a CTO. A balloon, after the balloon inflation, then simply cross the wire and finish it off. Crossed with a Congress Pro 12 and finish the case. Parallel wire technique. Actually, the first wire is kept as a landmark in the incorrect route, and the second wire is advanced manipulated. First wire is sitting there, and the second wire will help you to take the wire down and finish it off. Here is actually the first wire. Second wire helped me to go the procedure and finish it off. Sometimes a side branch technique where can be put a wire or a balloon may help you. A CTO OM2, a circumflex wire is put. After failing with the filter, Whisper and then a Congress Pro 12, I thought it is actually the wire was totally out of the track. A change of direction actually helped me to go into the right lumen. Just a change of direction. Soft handling and persistence is one of the key for always achieving a success in CTO. A CTO of 5 years, it's a floppy wire. I just tried with a floppy wire, but the CTO, the direction was not perfect. Even the wire was buckling out, and I was not able to, it's a long buckling out. Wire with the balloon also not going, so you can see. Somewhat promising, but not able to cross. Wire changed to Congress Pro 12, but totally out of the track. Wire changed to a 2 lumen, but I checked in different angles. One angle, second angle, then the third angle, which shown it is in the perfect place, and then finish the procedure. I was guided help you. A situation like this, maybe you don't know where the origin of the RCA occlusion. We really don't know. The wire with an IVUS helped me to proceed and finish the procedure. Retrograde technique. Rationale for retrograde approach is actually proximal fibrous cap is thicker and harder than the distal cap. Shape of the distal fibrous cap is often dome shaped. Retrograde is actually just a kissing wire or a cart or reverse wire. People usually there are two techniques. One is a kissing wire technique as well as this is actually the wire passed from the septal wire, retrograde wire and the RCA. I passed an anterograde wire, just kissed, and with the help of the second wire, I just passed and finished the procedure. CTO crossed with a congus and finished off. But actually, 2 stents in RCA, I saw ultimately the PDA is closed off. What I did is actually the lady wired. After stenting the RCA, I just passed wire through the PDA into the stent and created an opening, then antegrade I finished the procedure. Then antegrade I could finish the procedure. Wire passed antegrade and finished. The concept of card technique is actually create a channel in the antegrade with the antegrade wire and then finish the procedure. You use a double catheter. With the help of a corsair, you go down, you define your microchannel, then pass the wire into the RCA with the help of an antegrade wire, creating a channel, then reverse cart, serial balloon dilatation, escalation of the retrograde wire, balloon dilatation, antegrade through the retrograde wire, then multiple stents up to 4 here actually. Final angiogram, excellent result. Check angio after 1 year, this is the final result. Even in the retrograde approach in Japan, actually there is a change now. Nearly 25% of the patients, they are retrograde. Even the primary operators, 20% of the cases. The Corsair usage gone up, with the success rate gone up. They used a new balloon called epicardial channel usage gone up to nearly 20%. With the new wire came like Sion, actually already explained by why we are not doing retrograde that much. Cost involved is high because of the multiple wires, Corsair, 2 catheters, multiple balloons and multiple stents. Package goes up. If the patient comes for a second attempt, then we can try. But the second attempt cases are less because of the excellent surgeons available in the country. Other devices, Corsair is one of the tapered, soft tape 20 cm screw head structure, hydrophilic polymer coating, PTFE. Corsair can be used anterograde sometimes. It is definitely helping to cross the lesion. It is a microchannel which will create a success. Tonus is one of the devices sometimes used, very useful in actually instant restenosis. I tried in 1 or 2 patients, which is excellent. This is actually, I tried with multiple balloons, 1 point, wire crossed, but the lesion is not crossed. 1.25 is not crossing. Tonus tried. Tonus down here. Then serial balloon dilatation, 2 long stents and procedure finished. I have done nearly 850 angioplasty CTOs from 2003. The total number of CTO done is 315 with a success rate of 80%. At 246 successful CTOs, I just go, we only requires in successful CTOs require 1 to 6 wires with the 3 stiff wires in 4 cases. That is what I have analyzed. And in a failed case, nearly 7 wires used in every failed case with the 2 to 3 stiff wires. A combination of wires comes to nearly more than 1 wire is used in nearly 80% of the cases, and 40 cases I just use 1 wire, and a floppy or a polymer coated wire used in all cases as the first wire, except in 16 cases, nearly 6.5 cases where it was tried earlier, I just use a stiff wire. At 27% of the cases I could complete the procedure with only a floppy or a polymer coated wire. Last 2 years I just analyzed the last wire to cross. You can see that 27% of the cases I used a floppy wire in till 2010. Then last 2 wires, 30% of the cases only a plastic coated wire because the excellent devices available now. And the last 1 year, 35% of the cases with a floppy wire. So wire cross without a balloon, without the help of a device or a balloon is only 37, which is very number, less than 15% of the cases. When you fail what you do, start over, trust your skill, be persistent and get help. It can be dangerous, it is not that encouraging, but some of the cases. I analyzed the data till 2011, actually 42% of the case I could not pass the guide wire and 28% of the case I could not pass the balloon even, dissection and extravasation 28% and cardiac tamponade 2%. Were actually unsuccessful in the last 1 year data I just analyzed. 77% of the patient I could not cross with the guide wire. I saw this is a major lesion, tortuous and the calcific lesions which create a real problem for the CTO operators. Is there a time not to try? Yes, a long tortuous CTO segment not to try, severe calcific lesion not to try, a poor distal visualization not to try, especially when no prospect for a retrograde cannulation. Wire or device perforation with pericardial effusion, hemodynamic instability, collateral vessel compromise, extensive dissection, contrast threshold, radiation threshold, better stop it. Patients required for any CTO operation, tailored approach of guide wire is a very excellent way of looking into. Plastic coated floppy wire, gone up, numbers gone up even in the worldwide. Majority of the cases can be done by anterograde. A robust anterograde techniques are mandatory for a retrograde cannulation. Thank you.